Project First Line, Enhanced Barrier Precautions. In this presentation, we'll begin by discussing multi-drug resistant organisms and why they pose challenges. Next, we'll review precautions, starting with standard precautions, followed by transmission-based precautions, and leading into enhanced barrier precautions, which is our key focus. Lastly, we'll finish with common questions. Before we begin our conversation on enhanced barrier precautions, it's helpful to understand multi-drug resistant organisms and why they are a concern in nursing homes. What is a multi-drug resistant organism? A multi-drug resistant organism, or MDRO, is a germ, predominantly bacteria, that has developed resistance to one or more classes of antimicrobial medications. MDROs are hard to treat and can increase the risk of severe or prolonged infections. They also limit treatment options, making them a serious concern in any healthcare setting. Nursing homes are at a higher risk of MDRO transmission due to the close contact that occurs between residents and staff. MDROs are a concern because if it cannot be contained, it can then spread through contact with hands, shared medical equipment, or contaminated surfaces. Examples of MDROs currently targeted by CDC. At a minimum, enhanced barrier precautions are intended to be used for residents who are colonized or infected with novel MDROs, MDROs that are currently targeted by the CDC, as well as those at increased risk for MDRO acquisition. Examples of CDC-targeted MDROs are displayed on the slide. Examples of MDROs that might be epidemiologically important locally. In addition to the CDC-targeted MDROs, there are others that may be epidemiologically important at the local level, including those displayed on the slide. These organisms may not be on the CDC's national target list, but can still pose significant risks depending on the local context. Determinations about an organism being epidemiologically important may be influenced by factors that include local epidemiology, presence of ongoing or past outbreaks, propensity of transmission in healthcare facilities, association with severe outcomes, or targeting for local prevention efforts. Residents at increased risk of MDRO acquisition. Some residents are at a greater risk for acquiring and spreading MDROs. Two important risk factors include wounds and indwelling medical devices. It's important to remember that the wound or device itself does not cause an MDRO. Instead, these conditions can create additional opportunities for germs to enter or leave the body and often require frequent, hands-on care and contact with healthcare personnel. Increased contact can create more opportunities for contamination of hands, clothing, and shared medical equipment. Enhanced barrier precautions, or EBP, help to reduce these opportunities for transmission during high contact care activities. Next, we'll take a closer look at wounds and indwelling medical devices and discuss what meets criteria for EBP. Wounds and MDRO risk. Let's now take a closer look at wounds and how they relate to EBP. Not all wounds meet the criteria for EBP. The guidance focuses on chronic wounds that require ongoing care because these situations may create additional opportunities for MDRO acquisition and spread. Examples include pressure injuries, diabetic foot ulcers, chronic venous stasis ulcers, and other wounds requiring continued dressing care. It's also important to understand what is not considered a wound for EBP purposes. Minor skin tears, small skin breaks covered with a simple dressing, and short-term wounds expected to heal quickly generally would not meet these criteria. Ostomies, such as colostomies or ileostomies, are also not considered wounds under this guidance. Remember, EBP focus on residents with chronic wounds requiring ongoing care rather than short-term or minor skin injuries that can be covered with a Band-Aid or similar dressing. Indwelling medical devices and MDRO risk. Let's now take a look at indwelling medical devices and how they relate to EBP. Similar to wounds, the presence of a device itself does not cause an MDRO infection or colonization. However, these devices can create additional opportunities for MDRO acquisition and spread because they provide a pathway into the body and often require ongoing care and frequent hands-on contact. Examples of indwelling medical devices that meet EBP criteria include urinary catheters, central vascular lines, including PICCs, feeding tubes, and tracheostomy tubes. These devices often require routine management, dressing changes, or other care activities that can increase opportunities for contamination of hands, clothing, and shared equipment. Examples of devices that are not indications for EBP include peripheral IVs, continuous glucose monitors, and devices that are fully embedded within the body, such as a pacemaker. Colonization versus infection. It's important to understand the difference between colonization and infection because both have implications for how we approach care. When a resident is colonized, the organism is present on or in the body, but there are no signs or symptoms of infection. Colonized organisms can live in places like the skin, nose, wounds, the GI tract, and around devices. Importantly, a colonized person can still spread the organism to others, and colonization may persist indefinitely. Remember, we cannot assume that no symptoms means no risk. Infection, on the other hand, means the organism is actively causing illness. Signs and symptoms may be present, and the resident often requires clinical evaluation and treatment. Infection may also increase the risk of complications. Understanding this distinction matters because residents who are colonized may not appear sick, but can still spread MDROs to others. It's important to remember that enhanced barrier precautions are recommended for those with MDRO colonization and MDRO infection. Impact and burden of MDROs in nursing homes. MDRO transmission is common in nursing homes and contributes to substantial resident morbidity and mortality, as well as increased healthcare costs. There are a few key reasons why nursing home residents are particularly vulnerable. First, residents often have wounds or indwelling medical devices, which increases their risk of MDRO colonization and infection. Second, colonized residents may carry MDROs without any symptoms at all, increasing the risk of silent transmission to others. These factors combined make nursing homes a high-risk environment for MDRO spread. Risk factors for MDROs. There are several key risk factors that contribute to MDRO transmission in nursing homes. Let's start with the resident-related risk factors. Residents may have long-term health conditions that can weaken the body's defenses and compromise the immune system, making it harder to fight infections. Next are healthcare-associated exposures. Recent or prolonged time in clinical settings increases a resident's exposure to MDROs. Also, indwelling medical devices such as Foley catheters, central venous catheters, and feeding tubes increase opportunities for MDRO acquisition and spread. Another risk factor is antibiotic exposure. Antibiotic use can upset the body's natural defenses, promoting the growth of resistant organisms. Sources of MDRO spread. Beyond resident and healthcare-related factors, let's look at other sources that also contribute to MDRO spread. Starting with environmental contamination. This includes high-touch surfaces like bed rails and door handles, as well as shared spaces, which can all act as reservoirs that enable MDROs to spread. Next are shared medical equipment. This includes reusable devices such as blood pressure cuffs or assistive devices that can spread MDROs if they are not properly disinfected between uses. And as we mentioned earlier, colonization means residents may unknowingly carry and spread MDROs through contact with healthcare workers, shared equipment, and surfaces. Colonized residents can cause spread without showing any signs of infection. Reducing MDRO transmission. Given the established risk factors for MDRO transmission in nursing homes, targeted infection control precautions are the primary tool for reducing spread and protecting residents and staff. Let's take a look at the three types of precautions used in healthcare settings. There are three categories of precautions used in healthcare settings. Standard precautions apply to all residents in all healthcare settings and includes PPE use based on anticipated exposure to blood, body fluids, and contaminated surfaces. Transmission-based precautions are used in addition to standard precautions and are implemented for residents suspected of having or confirmed to be infected with certain infectious agents. This includes contact, droplet, and airborne precautions. And finally, enhanced barrier precautions. These precautions are an infection control strategy specific to nursing homes and are implemented for residents with an MDRO or at increased risk due to wounds or indwelling medical devices. We'll focus on enhanced barrier precautions for the remainder of this presentation. Let's now take a closer look at enhanced barrier precautions. Enhanced barrier precautions. Enhanced barrier precautions, or EBP, are an infection control intervention designed to reduce the transmission of MDROs through targeted gown and glove use during high contact resident care activities, which we'll define in a later slide. A few key points to keep in mind. EBP is specific to nursing homes. They are used in addition to standard precautions, which are always in place. And EBP is implemented for residents at risk for or with a history of infection or colonization with an MDRO, as well as those at increased risk of MDRO acquisition. Components of EBP. EBP have four key components. First, remember to always perform hand hygiene before and after resident contact. Other times hand hygiene is performed includes before performing an aseptic task, before moving from work on a soiled body site to a clean body site on the same patient, after touching the resident's surroundings, after contact with blood or body fluids, and immediately after glove removal. The next component of EBP is PPE use, specifically gowns and gloves, which are required during high contact care activities, and other PPE may be recommended based on anticipated exposure. Next, there is no room restriction. Residents on EBP are not restricted to their rooms and do not require placement in a private room. And last is the duration of enhanced barrier precautions. EBP remains in place for the duration of a resident's stay, or until resolution of the wound or removal of the indwelling medical device that placed them at higher risk, so long as they had no history of MDRO colonization or infection. Why EBP matters. EBP helps to reduce MDRO spread within the facility. It also helps to protect residents and staff through the use of gowns and gloves during high contact care activities. And they help balance resident care and safety. EBP is designed to protect residents while still supporting their independence and social participation. High contact resident care activities. EBP applies specifically during high contact resident care activities, and that includes dressing, bathing and showering, transferring, providing hygiene, changing linens, changing briefs or assisting with toileting, device care or use, and wound care. Gowns and gloves should be worn during all of these activities for residents on EBP. It's important to remember that EBP is triggered by high contact care activities because those are more likely to spread MDROs to staff hands or clothing. Some tasks with limited contact when done by themselves and not bundled with other care, such as the combing of a resident's hair, may not require a gown and gloves. In general, assisting a resident with a transfer in common areas, such as dining or activity rooms, would not be recommended for gown and glove use when contact is expected to be short in duration. The key is the amount and duration of contact and whether the task is part of bundled close care. And remember, standard precautions should always be in place and always follow your facility's policies when implementing enhanced barrier precautions during high contact care activities. Supporting EBP implementation. Putting EBP into practice requires attention to a few practical details. First, ensure that signage is clear, consistent, and updated whenever precautions change. Visual cues help staff quickly understand what PPE is needed and when. Second, make PPE and alcohol-based hand sanitizer available immediately outside of the resident's room. This includes gloves, gowns, and hand hygiene supplies in a designated area, with a trash bin positioned inside the resident room and near the exit. Third, include EVS, dietary, and therapy staff in PPE planning and training. All staff who provide close contact care should understand when EBP apply, not just nursing staff. How long do enhanced barrier precautions last? EBP is part of ongoing resident care as long as risks are present. This is important because EBP is designed to prevent the spread of MDROs, including from residents who may not have symptoms. Many residents with MDROs are colonized for extended periods of time, and colonization can be persistent and recurrent. It's also important to remember that there is no fixed time limit for EBP. They should continue while the resident has a wound, an indwelling medical device, or is colonized or infected with an MDRO. Conditions for discontinuing enhanced barrier precautions. There are specific conditions under which enhanced barrier precautions can be discontinued for residents whose EBP were implemented solely due to an indwelling medical device or active wound, meaning there is no known history of a novel, targeted, or epidemiologically important MDRO. In those cases, EBP can be discontinued if the indwelling device has been removed and wounds have fully recovered. Always follow your facility's policies for stopping EBP. And remember, standard precautions remain in place and should always be practiced. We'll now take a look at a few common questions. Is PPE required for ancillary services, such as physical therapy or occupational therapy, for residents on EBP? Therapists should use gowns and gloves when working with residents on EBP in the therapy gym or in the resident's room if they anticipate prolonged, close body contact where transmission of MDROs to the therapist's clothes is possible. Are ostomies considered indwelling medical devices for the purpose of EBP? No. Ostomies do not require enhanced barrier precautions. However, standard precautions still apply due to the potential for blood, body fluids, and infectious material. Are gowns and gloves recommended for EBP when transferring a resident from a wheelchair to chair in a day room or dining room? In general, gown and gloves would not be recommended when performing transfers in common areas such as dining or activity rooms. EBP is primarily intended to apply to care that occurs within a resident's room where high contact resident care activities, including transfers, are bundled together with other high contact activity such as part of morning or evening care. This extended contact with the resident and their environment increases the risk of MDRO spread to staff hands and clothes. Outside the resident's room, EBP should be followed when performing transfers and assisting during bathing in a shared shower room, and when working with residents in the therapy gym, specifically when anticipating close physical contact while assisting with transfers and mobility. Hand hygiene is recommended before and after resident contact. Additional resources can be found on the following pages.